All right. Hello, everybody. My name is Chris Urbanek. I'm one of the physicians at Regenexx Des Moines, and thank you for joining us for our lunchtime webinar. The topic for today is going to be basically a look at what is platelet-rich plasma and what is bone marrow. What are the things that we're doing to treat? And so I've gotten a lot of questions in the chat as well as through email about kind of, what is PRP? Is there a difference between concentrated bone marrow and stem cells? And so today's going to be kind of a look at a little bit at the science and kind of the processing and what we do and what makes us different from other clinics that may say that they offer PRP. And so we'll kind of dive into that. So as questions come up, thoughts that you might have, feel free to put them into the chat. I will be addressing those at the end. And so let's start to dive in. I'm going to share my screen. Let's pull up our webinar. All right, so let's get into it. The first thing that I want to do is actually do a bit of a dive behind the scenes and look at what we have in our clinic that most clinics do not. So there's lots of things here on this slide, and I actually really enjoy it because all of these things are important. And it's really what separates us from your average stem cell clinic or even offices that are reputable, academic even, and say that they do PRP. So we're going to talk a little bit about kind of what we have behind the scenes. And so this is part of our lab work that we do in the processing of blood, whether it comes from peripheral blood when we do PRP or blood platelets, or whether it comes from bone marrow when we're looking for concentrated bone marrow or stem cells. And we'll dive into a little bit more about what each of those things mean. But this kind of gives you an idea as to kind of everything that we're doing. If you're a basic clinic that's dabbling in orthobiologics or regenerative medicine, really what you have is a bedside centrifuge. So kind of this top middle picture is really it. And you concentrate the blood that way, and you take out the part that contains the platelets and you re-inject that. But these centrifuges themselves also come in kind of different varieties as far as how high can they spin, how fast do they spin, and what are the protocols that are being used by the clinic to really make the blood product. The majority of clinics out there that are offering orthobiologics are doing what's called bedside centrifugation, meaning that they draw blood, again, whether it's from a peripheral vein, like when you donate blood or give blood for lab work by your maybe primary care or at the hospital. And then they spin it down. It takes about 15 minutes and they take the platelets out and then re-inject that. And it's largely a low volume. And it's typically rich in red blood cells, which we don't want. The red blood cells are inflammatory. And it's relatively poor in platelets. And again, we'll talk about some of the numbers behind that and why those things matter. But what we have is it's called flexible lab platform. And this allows us to be very, very precise with what we're gathering from you. And so in the top left corner, you can see what's called a biomedical safety cabinet. This is a sterile setup that allows us to work with the blood directly by our lab team and process it all by hand. And so again, many of these clinics, when I'm talking to patients, they said, "Oh, I've had PRP, it didn't work." I said, "Well, tell me about it." And they're telling me, "Well, they drew blood and 15 minutes later, they were injecting it." That's a good indicator that your PRP is a relatively low concentration because it takes time to get high concentration. And so our processing takes about 2 to 3 hours from the time that you give blood until the time that we're able to re-inject it into whatever the target site might be. And again, we've talked in several webinars in the past that we really treat fairly holistically, and we treat all body parts, spine, joints, tendons, ligaments, stuff like that. And so this is kind of unique to have this biomedical safety cabinet at a high level with lab tech that's trained to be able to do this kind of stuff. The other thing that you'll see here is cell sorters, cell counters, polymerase chain reaction, microscopes. These are all ways for us to look at the cells and actually validate what you're doing. And this becomes important because there's a dose response to platelets. So the more platelets you get, the more of a physiologic response or healing response that your body has. And so the other thing that I'll often ask patients is, "Well, what dose of PRP did you get?" They say, "Well, I don't know. I have no idea. They never told me." And they didn't tell you because they never checked in the first place. And if you compare that to literally every other area of medicine, you know what the dose is that you're getting. When you're on an antibiotic, there's a very specific dose. If you're on a medication for maybe heart or blood pressure, there's a very specific dose that you're on. And sometimes that needs to be changed depending on the severity of the disease. And a lot of times these bedside centrifuges that use a set kit will only concentrate to a specific level. Most of the time, what happens then is if a patient is told what their concentrate is, the physician that's typically administering that treatment only knows what the rep for the company is telling them. And we're going to look at that a little bit later too, as far as what some of these numbers are. Now, I do want to point out one thing on here, because some of this is for research as well, and not directly tied to clinical. You see that I have on here culturing. So the FDA does not allow re-injection of cultured cells within the United States. Regenexx does it in our Cayman's office, but we do it for research as well, so that we can test these cells and see what medications do they respond to, what medications hinder them. And so typically when we set up a treatment plan for a patient, we're talking about the medications that they're taking or supplements that they're taking that may impact their results. So the culture, again, this is not for re-injection of cells in the United States, but it's used for research so that we have kind of that advanced look at, how do we make sure that patients are getting the best outcome possible. So this is behind the scenes in our lab and gives you some information as far as, why do we do everything we do and how are we doing it in that regard. So I want to start to talk a little bit about platelets first, and then we'll branch out and we'll talk about stem cells or bone marrow cells. And so this is a very, very rough diagram of what a platelet really looks like. So a lot of times patients will think of platelets as the things that are more like inert pebbles that will clump up and can give patients heart attacks or strokes, or some patients are familiar with the idea that platelets stop bleeding, and that's what they do. But platelets are really a physiologically active cell. They have a process that they perform in our body when they're not stopping bleeding, and it comes from kind of these little containers inside of the platelets, and these are called granules. So this is marked as an alpha granule, and that's really the key player in orthobiologics that we're looking for the contents of that. There's also dense granules, which have an effect as well, but the growth factors in platelets are contained within these alpha granules. And so how do they get used? So if we use bleeding as an example, because that's a type of wound or injury that needs to heal, when you bleed, the platelets do clump together, they form a mesh that stops the bleeding process, but then they're kind of stuck in that mesh, and they go through a process of degranulation, meaning these containers migrate to the outside of the cell and dump out their contents. And those contents are very, very high in growth factors. And those growth factors do things like encourage fibroblasts to lay down tissue, or they increase blood flow to the area. And so with the blood flow brings nutrients. So lots and lots of growth factors. And that makes sense again in wound healing. So if we just step back from musculoskeletal medicine and just talk about how do wounds heal, this is what happens when you cut yourself. The platelets are actually the thing, when you think about it, that really heals the skin. They're sending out all these growth factors and signals telling those skin cells, hey, you need to make more skin. Hey, you need to bridge this gap. This is really the foundation for orthobiologics. This was a group in the 80s got together and said, hey, well, what if we concentrate those platelets and put them in areas that patients have injured in their knee or in their shoulder? Or the first published study was on lateral epicondylitis, or tennis elbow. And so that's kind of the foundation and why platelets work in this regard. And so what do? We take whole blood and we spin it down, and that gives us basically 3 layers. One layer is serum or plasma, and that's a very, very clear layer up at the top. At the very bottom is our red blood cells. And then in between the two is what we call the buffy coat. And the buffy coat is going to contain platelets and white blood cells. And so if we look at how that separation is done in kind of the commercial kits, which are largely referred to as PRP, they end up with a platelet concentration that's bright red or cherry red, or looks like a relatively clear kind of red solution. And that's because it still contains red blood cells in it. And the concentration of platelets will end up somewhere between about 3 and 5 times the baseline concentration. Meaning if you have X number of platelets in your blood per milliliter naturally, the end result is going to be 3 times higher than that per milliliter. This is one type of bedside centrifuge. There's another one that actually concentrates lower than this, but is red blood cell poor. So it'll also produce a clear sample, kind of like the one that we have demonstrating on the right. But it's because it's red blood cell poor, it's also platelet poor. And so the count of platelets is much lower than that. By having a flexible lab platform where we will manually process the platelets, take out exactly what we need, and we can select for, do we want white blood cells, do we not want white blood cells, we're able to come up with a very, very clear solution. So no red blood cells in it, which again are relatively destructive to tissue and they're a major irritant, but also very, very high in platelets. And we concentrate up until about 20 times baseline. which also means that our blood draws are a little bit higher. And sometimes that's a question I ask the patients as well when they're talking about, oh, I had PRP, it didn't work. And I go, well, how much blood did they draw? And they go, oh, they took a tube, they took 2 tubes, they took a 30 cc syringe. Okay, well, the best you're going to get out of that is 1 or 2 cc's of platelets if you're concentrating at a high level. So we also take a higher volume of blood. Now, of course, we follow American Blood Bank guidelines on that. We don't take too much blood that'll make someone anemic. And we actually check for anemia before we do a blood draw as well, so that we don't do anything that would hurt a patient. But we can get a very, very high concentration of platelets. Now, there's been some studies that have looked at some of these other systems, and one of my favorite researchers is actually this Jeremy McGallen. He's a French researcher. His background is in pharmacy, but has really embraced orthobiologics and is much like us, looking for objective evidence. What are the outcomes of that? And so this is a very busy slide, and he's actually done a newer one that has way more commercial kits than this, but I use this one just to keep things simplified. And so, these are the names of the kits at the top, and certainly it's not my intention to call anyone out, but these are commonly used kits. And so this may be what will be done in an orthopedist office, sports medicine, physiatry, pain management. And when you look at, the very first line is how much blood are they drawing? And it's like 4 cc's of blood. And so that's half a tube really compared to other draws. But what's interesting is this line here that I have circled. And it's telling you what is the concentration, how much more platelets are they getting per milliliter of solution or serum or blood, whatever you want to call it, compared to your baseline. And you see many of these kits don't even hit twice. They're not even hitting double the baseline. This one kit gets up to 4, which is great. That's certainly better than these. Now, my problem with this is these kits are calling themselves PRP, and the definition of PRP by Marks has to be a concentration greater than 2. And so, this is a little bit concerning because they're advertising that they do a PRP injection, but when these kits are actually studied, we're seeing a much lower volume than really what's considered PRP. But how would a patient know? You don't know unless you're doing the literature. And so that's why I think it's important to kind of look at some of this data. Now, you will see on this column that this was their lab in France, and they got fairly low concentration as well. But this goes back to kind of that first slide. We're testing every sample. I've done procedures today that I know the exact cell count. I know the exact dose that I'm giving to my patient, and that's exceedingly uncommon. So we're getting 14 to 20 times concentration, which is well higher than what a lot of these commercial kits are doing. And so why does it matter? Is there a dose response? Absolutely. This is a great example from research that we did at our headquarters in Colorado. And you can ignore the graph at the bottom. I really like the pictures because this is where money kind of talks, so to speak. So these are pictures from a slide in which we grew tendon cells. So the natural cells that support the health of our tendons, we grew them in a dish, but we did it with a barrier between 2 sections of cells. And so there was a physical barrier between the cells on the right and the cells on the left. And then we removed the barrier and we said, well, what happens over time? Can these tendon cells with some sort of stimulus, and in this case, platelet-rich plasma, can they bridge this gap? Can we make them grow? And when we do first as our kind of control is platelet-poor plasma. Now, platelet-poor plasma actually has some factors to it that can contribute to healing, but the change between the top and the bottom, as you can see after 48 hours, is pretty minimal. We're seeing a little bit of tendon growth, but certainly hasn't bridged this gap. And then we looked at several different concentrations. So about baseline concentration, which is what's naturally in our blood, but removed of red blood cells and removed of white blood cells. And we see that a little bit of healing occurs. And that makes sense. That's naturally how our body wants to heal things. That's how we heal our skin, as I was saying before. And then we said, okay, well, let's go up to a level that's fairly common in some of these commercial kits, about 3.5 times baseline. And now we are starting to see some bridging between one group of tendon cells and a second group of tendon cells. But then we get up into the levels that we typically concentrate at, and we're getting nearly complete bridging between the two. So just like the medications that you may be on or you may take, the dose is important. And so this is part of the discussion that I have with patients of as far as if they've had treatment before, figuring out what their outcomes were, but also figuring out exactly what amount or dose of platelets that they receive. And so this is a great example with tendon cells, but we know that this is true with cartilage. This is true with ligaments. This is also true with muscles. And so everything is kind of dose dependent. The other part that we look at is we can look at different patients of different ages. And we look at how it activates our stem cells. So our natural stem cells, which we have all over our body, our stem cells live inside of our bone, and they also live around blood vessels. And so again, if you cut your finger, the platelets are kind of the first responders. They're the ones there that are kind of bathing the area in growth factors. But then the stem cells migrate in, and part of that is because of the signals, the growth factors that the platelets are putting out. They're saying, hey, there's an issue, we need helpers, let's mobilize this force. And so, I love this graph because it's very, very fascinating. So we also split this up by patients' age range. And so we had patients in their 30s, in their 40s, and in their 50s. And as we looked at some of their cells through a research study, again, at our main clinic in Colorado, we looked at how much can they proliferate, mobilize, or activate stem cells. And that's MSCs, mesenchymal stem cells. These are the guys we think are major players, but not the only players in musculoskeletal healing. And so you can see, just at first glance, you can see, okay, look, our 50-year-old group actually responds more than our 40 and 30-year-old group. And I'm going to talk a little bit more about that. But the important thing first is this dose response curve. And so the higher the level or concentration of platelets, the higher the dose that's being delivered, the more stem cells are actually recruited to that site to help heal. And that's true in every age range. So the question should be, why do we see more of a response in our 50-year-old group than in the 40 and the 30-year-old group? And that has a little bit to do with the way that cells regulate themselves in a given environment. And so in our 50-year-old group, our cells in whatever area is injured or has a problem typically have lower saturation in natural growth factors. Our innate healing response is a little bit lower. So that means that the cells have to put more receptors on their surface so that they can grab onto those growth factors as they come by. They're more sensitive to it. And so they're grabbing onto any little bit of growth factor that comes by. And that's why we see a greater response, because those cells are actively hunting down growth factors because they're typically not saturated by it. And in our 30 and 40-year-old group, we believe that the cells that are there actually have a natural amount of growth factors that are there. So there's less cellular receptivity, meaning those receptors, we use terms like downregulated. So there's less receptors because they're seeing growth factors at a natural basis on a more regular basis. And so we don't see this big response. Now, this is essentially a Petri dish study where, again, we've looked at concentrated platelets at these different levels on the right and how their stem cells responded to it. But what this graph doesn't show you is the thing that I just talked about. This group that has a lower response than the 50-year-olds have naturally circulating growth factors that are also going to contribute to the stem cells. So all in all, the graph ends up being even for each dose of platelets because there's already the natural growth factors that are in higher quantity in our 30 and 40-year-old group compared to the 50-year-old group. So it looks like I said, the first instinct is you go, oh, well, our older patients respond better. But no, that's not true. Our younger patients respond just as well when you take into consideration the natural growth factors that are there. And so it all kind of evens out. I'm going to shift and start to talk a little bit about bone marrow cells, or what many patients call stem cells. And this is kind of like talking about the platelets. We first have to come back and say, well, wait a minute, how are we even getting these? Where are they from? What's the process for obtaining a good bone marrow draw? So like I said, bone marrow is found in two places, around our blood vessels and or inside of bone. And so we harvest from the sites that have the highest concentration. And so this is a cartoon of kind of what our pelvic bones look like. And the important one is this big broad bone up on their top. This is our iliac crest. You can see the rest of the anatomy here. There's the lumbar spine, there's the sacrum, and then there's our top of our thigh bones, and the hip joint is part of that too. But in this area, the bone is quite thick and it has a high concentration of platelets. So starting right off the bat, you need to be seeing a physician that knows where to go to get the goods, so to speak. There are lots of physicians that will get platelets from other areas, including the shin bone, which is what this study shows. I've also had patients tell me that they've had harvest from their heel bone. And that's typically podiatry and foot and ankle surgeons that like to take it from there because that's the area that they're working on anyhow. They often use that to augment the surgery. But the count is much lower. It's about twice. Which is a big difference when we're looking at kind of effective dose of bone marrow or stem cells. But this is the area that we kind of target. And we're going to look at what that looks like in a cross-sectional view. So here's kind of the same area. This bone, as it comes up, is the back of our iliac crest. And it gets to a thin area down below. You can see part of the gluteal muscles on this side, as well as some of the pelvic muscles on the inside. You can actually see part of the sacrum back here as well. So when we draw bone marrow, you need to do it from the right place, meaning it has to be done under image guidance. There are some doctors that will do this blind, meaning they push on the area, they feel the iliac crest, and then they kind of put the needle in and pull out whatever they can get. But I think you should note how different the thickness of the bone is, being this whole area more superiorly, higher up towards the lower back, versus the area down low, which is very, very thin. So if you have a needle that passes down into this thin area, it's very easy to punch through into the pelvis, which again, in this cut, we're seeing muscle, but this is also where our abdominal contents live. And so that's poor form to go into the pelvis. We want our needle to be here, and that can really only be done under image guidance, and whether that's fluoroscopy or ultrasound. And that's what we typically do. And the approach is also important too. So if we look at kind of the direction that you can come in, our approach is typically from the side, coming in and getting into this marrow cavity. And again, you can see this really nice marrow cavity. It's kind of filled with a mix of fat, which is the white, and red cells, hematopoietic cells, bone marrow cells, stem cells. That is what we're trying to harvest and pull out. But we typically do multiple sites, and we'll fan out. You can imagine if I step back from this film, maybe a centimeter, that's another site. Or if I move forward a centimeter, that's another site. So we can go kind of forward and backwards along this thickened area of bone as well to get these marrow cells. Like I said, our approach is typically multiple points. And if we look at the arrowhead, we're going to pull as we aspirate the bone marrow out in basically a circle around the tip of the needle. And we're getting the cells that are in the highest concentration, which live just under the edge of the bone at each of these sites. Now, the other approach, which really started with the hematology oncology doctors that are doing bone marrow aspirations to look for stuff like leukemia, bone cancers, other blood abnormalities, they do typically what's called a deep dive, meaning they come straight in through the middle along the axis of the bone, and they're pulling from the center of the cavity the whole time up. So they'll typically either advance all the way and then take aspirations as they pull the needle back, or they'll punch into the bone and then take aspirations of fluid as they advance the needle. But now they're not in a rich environment for the bone marrow cells or stem cells that we're interested in healing, and they don't have to be. But this becomes important in regenerative medicine because when we kind of first started doing this, not many musculoskeletal doctors, whether it was pain management, sports medicine, really knew how to get high quality stem cells. So they were taught by hematology oncology to do this long dive. So you may have a physician who's trained in regenerative medicine, but they're still using a little bit of an older approach and not getting any of those cells that sit right against the bone, which is really what our approach is. And we studied this in our headquarters as well, and that's what this shows here too. So even when you're in the right site, which is, again, this is iliac crest, so regardless of the approach, you're in the right area, so 2 times higher than being in the shin bone. But you're also 2 times higher by doing multiple sites and small draws and really trying to target these cells that are within the subcortical bone or just beneath the bony layer inside the bone marrow cavity. So you're seeing about a twice difference here. So this impacts the amount of cells that can be delivered. And as we talk about, dose is important. And so again, this is something that you have to consider when you're looking into undergoing one of these treatments, that they're harvesting in such a way that you're getting the best possible chance of a good response. We're going to talk a little bit about the stem cells here. This is a great slide that I took from one of our free ebooks. So if you go to the Regenexx website, click on resources, and then click on ebooks. There's plenty of free information on there. The Orthopedics 2.0, which I've referenced down at the bottom corner, has this picture in it, which I'm using for this presentation. It also has a wealth of other information. It talks a little bit more about our perspective and how we treat patients and why it's not okay to just put PRP or stem cells in a joint and nothing else, that we really need to treat the whole joint like it's an organ and look at some of the extra articular or structures outside of the joint that are important in how we manage things. And so that's oftentimes what you hear us talking about injecting ligaments and tendons. Even if they're not a pain generator, they're important in the health of the joint. And so we'll kind of talk about a couple of these here. And so if we look at the very, very far left, both of these are ways that we can process bone marrow cells. And so this is a great picture of a separation of a blood product. So this is actually what PRP looks like after its first spin as well. Here's those red cells at the very bottom that I was mentioning. The clear solution at the top is serum or plasma. And then there's a very thin line in the middle. And whether it's platelets, this is going to be white cells and platelets, or whether it's bone marrow, in which case this is going to be our bone marrow cells, this is our important layer. So we then extract the cells that we want from this layer. We spin it through a centrifuge and we concentrate them. And then this is what becomes part of our injection. The other treatment that we do is we take basically these cells out, we put them in a petri dish, and we culture them. We tell them, we give them growth factors to grow, and we multiply the amount of bone marrow cells that are in there. And then we come up with a solution that really contains only the mesenchymal stem cells, the ones that we think are most important in musculoskeletal healing, multiplied to a much higher level than what's found natively within our bone marrow, and we re-inject that. Now, as I said before, the FDA considers this to be a drug because it's been processed and it's had growth factors added to it. So this can only be done outside of the United States. And again, Regenexx has a Cayman office in which we do that. Now, there's another source of stem cells that really comes from, like I said, the perivascular space. So because our stem cells live in one, our bone marrow, and two, around vascular or blood vessels, we can harvest from fat, which is typically vascular rich. And so we do occasionally use fat grafting, but really within our Regenexx network, we don't use it as a primary source of stem cells. We use it more as a scaffold because the fat content, the fibrovascular tissue, provides kind of a scaffolding for the cells to then expand into, whether it's from a tendon or a cartilage injury, and can be injected in more of that fashion. We do see much more literature published on bone marrow cells, so there's more evidence existing for it, but it is building for adipose or fat-derived stem cells as well. And so this within the United States is what we typically see, where we take a graft or a micro lipoaspirate, and we spin down the part that we want. The part that has the cells in it is within the fat. We get rid of the liquid, and then we can re-inject that in a manner that I already discussed. You can also process it with an enzyme, which breaks up the fat and separates the stem cells from it. And you end up with what's called a stromal vascular fraction. That's intended to have more stem cells and less fat and vascular cells and fibrous tissue to it, and is thought to be a little bit more pure. But again, the FDA says that's a drug because it's been processed in some fashion. And so that can only be done in research or outside of the United States. And then the last one is to actually take those cells that you've isolated and grow them within a culture. So much like doing the bone marrow cells, you can get very high concentrations and re-inject those as well. And again, that's not something that we typically see. When I'm talking to patients about the procedure, many patients say, well, can't you just take my fat cells? It seems simpler. And the answer is no. It's actually easier to take from the bone marrow. The procedure is very well tolerated. We studied that as far as patient perception of the procedure. 80% of patients said mild pain or less during a bone marrow aspiration. And I would say that that's true in my practice from what I see. It's very, very well tolerated. And it has the lowest rate of adverse risks. So adverse risks would be bleeding, could be injury to the bone. You could sometimes get a seroma or fluid pocket, and it's exceedingly rare. It's about 1 in 1,000, whereas the data on doing a mini liposuction is anywhere between about 1 and 8% of patients have adverse risks, and they tend to be a little bit more severe, like skin necrosis, where the skin has lost some of its vascular supply, which comes from deep to superficial through the fat, and the skin actually starts to die. So while for many patients this sounds more appealing, it is safer and more effective to actually get our cells from the back of our iliac crest. So that's kind of a nice breakdown on the different types of, again, what most people call stem cells and what their role is and how they're collected. The other question that I often get is, hey, Dr. Urbanek, I've been told that because I'm older, my stem cells aren't any good and I need to use someone else's cells, and whether that's amniotic or placental cells or Wharton's jelly, any of those things that are not derived from you. And we've studied this at length, and that's not true at all. So this is a scatter plot of cultured stem cells, again, used for research, not for re-injection, and looking at this across many patient ages. And we do see a higher level, typically around the age, in the teens primarily, in many of our patients, but it's really even pretty much across the board. And so you can look at any of these plots and say, okay, well, here's the cluster is right about here in this graph with a couple outliers, but for the most part, everyone's concentrating to about the same level, all the way up to about 80. And the same thing as you look through all of these. So patients here up to about 80, plotting up into the same level of concentration or total number of colonies as we culture them out and study them in a lab. And the same thing in kind of each of these. Yeah, there's a couple outliers, but when you look at kind of the cluster where everyone is, everyone's really at the same level. And our perspective is that it really has more to do not so much with age, but potentially comorbidities and things that can be acquired over age. So we know that tobacco is a hindrance. We know that alcohol is a hindrance. We know that certain cholesterol medications can hinder the effect of our platelets, or I'm sorry, of our stem cells to grow and have good high numbers. And so those are the things that are typically more important as opposed to the number of birthdays that you had. So this is not a reason to say, oh, we should use somebody else's cells. Your cells are still the best cells for you. And if the procedure is done correctly from the very beginning, which is how is it even harvested in the first place, to how is it processed, to how is it re-injected, you're going to get a high quality stem cell product as far as part of your treatment. The other thing that we often compare this to is those umbilical cord or allogeneic product, which, like I said, can come from umbilical cord, placenta, amniotic tissue, Wharton's jelly, all of these things. And this is a great study. I'll move my little block out of the way here. Great study looking at culturing these commercial kits. And so all of these names at the top are from commercial companies that sell these allogeneic products. And so again, at our headquarters, we said, okay, well, we know stem cells grow. They've been doing it since 2005, Dr. Centeno. And so he said, well, let's just grow them. Let's see what happens. And they're stained purple for cell counting purposes. And so at the bottom are samples of bone marrow. And so these are patients, and you can see their ages, and they're growing a ton of stem cells. That's what every little purple dot is, a stem cell colony. So we're seeing tremendous growth from bone marrow cells, which is what we would expect, because again, this is something we've been doing since 2005. But when we put the allogeneic product, again, in this case, it was umbilical cord. When we put those in the growth medium, there is zero purple. There is no growth from any of them. And that's what multiple studies have repeated this and found the same thing that we did, that there are no viable stem cells in allogeneic products. And it makes sense, again, when you go back to some of the basics, the science, as to why this is. So these products have to be irradiated, high levels of gamma radiation, to kill off things that we don't want in there, like HIV, hepatitis C. And yet there's still reported patients of getting infections from these products. Some are bacterial, some are viral. And then there's a whole slew of other things called graft versus host versus graft, that confound that as well. But when you expose these products to the radiation that's needed to kill off the things that can cause infection, you're 100% killing the stem cells as well. So there are no viable stem cells left in this product. And that, it kind of makes sense too, when we think about how amazing our bodies are. This is one of the reasons that our stem cells are inside of our bones in the first place. It's to keep them protected from stuff like radiation. And we actually know that there's some fish models where the fish's stem cells are actually covered by a layer of melanin, the thing that colors our skin. And that's to keep those cells from getting any UV radiation that would make it through the water to the fish. So our body has innate protective mechanisms to keep these cells, because they're very important, but also fairly fragile. And so when you expose them to all this radiation, they all die off. And so this is kind of what separates us from any other stem cell clinic, is not only are we doing the procedure at the optimal way, but we also have a very, very firm understanding of the underlying science. So we're not just saying, oh yeah, I got some stem cells, I injected them into the joint. We know the exact dose, and we're putting them in the places that are going to help out. So that's kind of a review, a little bit of the background science and a look behind the scenes at our clinic and kind of what we do to give you the best possible result. If you do have questions, please feel free to put them into the chat now. I'll start going through those. If you have areas that you'd like me to go over in future webinars, please feel free to email me, and we will certainly address all of those concerns. So I'm going to end this slideshow, and let's go back and see any questions. So I will pull up the Q&A in the chat. And so certainly, again, as questions come up, I see Christine Miller has her hand raised. Christine, if you want to just type that into the chat real quick, we will certainly address whatever questions or concerns you might have. Otherwise, I do hope that you all found this interesting. I hope it was informative. And again, as questions come up, please certainly feel free to reach out. We'll give Christine a minute or two to write up her question. There it is. So Christine's question is, can you do stem cell after other procedures like cortisone shunt or hyaluronic acid injections? Wonderful question. We see this all the time in clinical practice. Many patients will come to us after other treatments have not given them great success. And so the concern with cortisone is it really hurts the cells that are, one, there natively. So our natural cartilage cells that live, say, in any given joint, like a knee, hip, shoulder, it actually makes those native cells less able to do their job. And there's a wonderful study that came out in 2017 that shows that sequential repeated steroid injections increase cartilage degeneration by about double. So it's not just like, oh yeah, it's not good for the cartilage. It's actively hurting the cartilage and speeding up arthritis by about twice the pace as if you did nothing. And so that's just baseline cortisone. The other thing that we know is that it hurts our native ability to heal cells because cortisone suppresses those cells and doesn't make them as effective. The same cells that cause inflammation are actually part of our healing process. And so it hinders their ability to do their job. And so typically we'd like to get about 2 months to 10 weeks out from prior steroid exposure into a joint so that those cells have had a chance to recover. Steroids are relatively quick acting, but their effects on cells are very, very long acting. And so even though the steroid's been out of the system for weeks, the effect is still persistent and we need that to go away. Hyaluronic acid injections are, I think, a nice modality to have in that they don't cause the cartilage destruction that we see with corticosteroid. They don't have any of the other side effects too, like sleeplessness, hunger, facial flushing, all of the other kind of bad side effects to steroid. They don't elevate blood sugar like steroid does. They don't decrease bone mineral density like steroid does. And so it's a good option. The efficacy of those shots is a little bit debated. There's some literature showing that they can do a really nice job of delaying symptoms associated with primarily knee osteoarthritis. And there's some data that says that it may work well in conjunction with platelet-rich plasma as well. And part of that has to do with how it changes the environment of the joint from a terribly pro-inflammatory environment to more of an anti-inflammatory environment that's a little bit healthier for the cells. So we do not have any limitations on hyaluronic acid injections. And sometimes we'll use them as an adjunct to our procedure as well when it's appropriate. But we have lots of other tools too. There's other things that we make in our lab that can be useful for inflammation. One of them is called A2M. That's alpha-2 macroglobulin. And that's a protein that's very anti-inflammatory and can help with patients, particularly those that have recurrent effusion or joint swelling. It can take some of that swelling away and make it less likely to return. So I hope that answers your question. It's a very, very good question, and it's something that we see in clinical practice all the time. And then a follow-up question, can you do stem cell after knee surgery? So yes, and it depends kind of on the surgery itself. And so we do often see patients that complain of knee pain after arthroplasty or knee replacement surgery. And so number one is finding what's the cause of their pain. And so the surgeons typically write this off because they say, well, I replaced the joint, there is no cartilage, you can't feel the metal implant, right? Because that's what knee replacement is knee replacement is an amputation and installation of a prosthesis that's on the inside of the body. And so you can't feel the edges of the bone there. And so the surgeons typically write this off, but we often see other things associated with it. We see ligaments that are too loose, and so we can tighten those up. When the ligaments are too loose, the tendons have to work overtime. So they're overworked and underpaid. So oftentimes treating the tendons around the replacement can make symptoms go away. And sometimes we see pain from the scar itself, where the surgical incision has scarred down, sometimes attached to the tendons on the top of the knee, and we can go do a couple procedures to break that up. But as far as treating inside the joint, we do not, because again, there is no structure inside the joint that is amenable to orthobiologics once you've had an amputation and installation of a prosthesis. Ken has kind of piggybacked onto that and saying similar question regarding after meniscus repair surgery. Absolutely. And that's one that we see a lot of. Patients have said, oh, I had meniscus repair, or I had a clean out, right? That's kind of the common term. Oh, I had a clean out. Well, clean out typically means that they take out meniscus that they think is causing a problem. And so that means that your meniscus is now smaller because you had a vital structure of the knee taken away from you. And so there's less meniscus there to do its job, which typically means there's more stress on the bone. And we talked in the knee osteoarthritis webinar, which you can find on YouTube if you'd like to see that one. We talked a little bit about how it's actually the bone that can be causing some of the symptoms in this case because the cartilage isn't doing its job, and we'll actually treat inside the bone as well too. And we see very, very good outcomes with that. Sometimes it requires just a touch up to the meniscus, and maybe we do that with just a little bit of platelets, or maybe we do it with bone marrow. It's really an individual case, but yes, oftentimes we are treating the meniscus. I find tears quite frequently under ultrasound. So every patient that I see gets a full diagnostic ultrasound in the clinic with me, and I often find meniscal tears. And so we will very commonly treat those and get it to a point that surgery is not necessary. But if you've had surgery in the past, we can make the cells that are there, the tissue that's remaining, healthier and better able to do its job. Or we can find the other pain generator, which often in this case, as the meniscus is less available, there's less cushioning, cartilage sees more stress, so it becomes thinner. The bone then has to adopt that stress. And a lot of that pain actually comes from the bone itself. So sometimes we have to treat inside the bone. So really wonderful questions from both of you. Thank you for contributing to that. Christine Miller, is there any insurance that will cover any of your procedures? No, not big insurance companies that will cover it. We do work with self-pay insurance. And so we have a corporate office that collaborates with companies that do self-pay for their insurance. And we're included as a benefit for about 5 million Americans for within their kind of self-paid insurance program. But if we're talking about the big players, United, Blue Cross Blue Shield, Medicare, Medicaid, none of those cover their procedures. And we're working on educating some of these insurance companies. Dr. Centeno, again, our chief medical officer and my mentor, is a big advocate for looking at cost savings as well as patient quality of life outcomes, and published recently a really nice study looking at patients requiring bone marrow level treatment for their knee and requiring even looking at several treatments over their lifetime compared to what knee replacement yields. And even patients that get multiple bone marrow treatments is a cost saving for the insurance company compared to a knee replacement. And the quality of life for the patient is higher as well. So that's something that maybe we can talk about in one of the future lectures or webinars as well, because there is some really good data coming out that shows that we're improving quality of life and saving money at the same time. Yeah, and Christine says that she's not a fan of insurance companies. Understood. So, well, everyone, unless there's any other last minute questions, I'd like to thank you all for coming. Please feel free to email me with any questions, or if you have any ideas for content that we'd like to be covering. I'm happy to review those and certainly add them to our schedule. We will be doing another lecture in about 2 weeks, and we're trying to hit different topics each time. So please feel free to join in then, and it'll be great seeing you. Otherwise, I hope you have a great day. Take care.